Welcome to today's KHA Quality Webinar. I'm Jessica Covington, the KHA Quality Program Pharmacist, and I'm pleased to have you join us today for this peer-to-peer learning session. We're so excited to welcome our presenters from St. Joseph Hospital, who will be sharing their innovative project, Preventing the Preventable, enhancing VTE prophylaxis in hospital settings through pharmacy-driven intervention. We do appreciate their willingness to share their experience and insights with us today. Now, before we get started, I do have a few quick housekeeping items. Please feel free to use the chat feature at any time if you have any questions or comments, or you can come off mute. Today's session is being recorded, and the recording will be posted on the KHA Quality website later this week. And lastly, in accordance with our privacy guidelines, AI-generated features, including transcriptions, are not permitted during this session. Now, before we begin today's presentation, I'd like to take a moment to highlight why this project is so important. Now, each year, hundreds and thousands of Americans experience a VTE, and tens and thousands die from complications related to blood clots. Now, for hospitals, this is especially significant because hospitalization itself is a major risk factor for developing a VTE. Now, patients, they're immobile. They may be recovering from surgery, or potentially they could be critically ill, or even just being treated for an acute medical condition. They're all at risk for an increased risk of clot formation. Now, the good news is that VTE, it is preventable. There's evidence-based prophylaxis strategies that have been shown to significantly reduce the incidence of these events and improve patient outcomes. Now, this is one of those areas where a targeted and it's relatively straightforward interventions can make a meaningful difference in patient safety, and also we're saving lives. Now, let's take a few moments to review the CMS quality measure focused on VTE prevention in hospitalized patients. This measure is especially important because deep vein thrombosis and pulmonary embolism are among the leading preventable causes of hospital-associated morbidity and mortality. Now, since hospitalization itself significantly increases a patient's risk of developing a VTE, ensuring timely and appropriate prophylaxis is a critical component of patient safety and quality of care. Now, the CMS measure 108 is often referred to VTE-1. It evaluates whether eligible patients received appropriate prophylaxis shortly after admission, or whether there is a documented clinical reason why prophylaxis wasn't appropriate. Now, this measure isn't just about checking a box. It's about making sure we protect patients from one of the most common preventable cause of hospital harm. Now, from a hospital perspective, these are just a very few reasons why this measure matters. Now, first and most importantly, patient safety. Preventing a DVT or pulmonary embolism, it saves patients' lives. Second, there's a CMS quality measure that we've talked about that contributes to a broader quality reporting requirement and reflects how consistently we deliver evidence-based care. And third, there's a financial and organizational performance implications. Performance on quality measure influences public reporting, benchmarking, and increasingly affects how organizations are viewed by regulators, payers, and patients. So when you perform well on VTE prophylaxis, you're demonstrating that you have reliable care processes in place and you're proactively preventing avoidable harm. So what does success look like? High-performing organizations, they don't rely on memory. They build BTE prevention into their workflow. That means standardized admission order sets, risk assessments, clinical decision support, and ongoing education for providers and staff. It also means paying close attention to documentation and following up on those missed doses or exceptions. And one of the biggest opportunities we often find is making sure that prophylaxis orders are not only entered, but that they're actually administered and documented correctly. Now, VTE prophylaxis is one of the clearest examples of how a quality measure aligns directly with patient safety. So when we consistently identify risk, we provide timely prophylaxis, and we document appropriately, we improve outcomes for patients while also meeting important CMS quality expectations. So now that we've discussed why VTE prophylaxis is such an important patient safety and quality priority, I'd like to shift from the what and the why to the how. We know that achieving high performance on VTE prophylaxis requires more than policies and protocols. It requires reliable systems, interdisciplinary collaboration, and real-time action at the bedside. That's why we are so excited to hear from a hospital that has successfully transformed its approach to VTE prevention and achieved meaningful improvements in both quality performance and patient outcomes. St. Joseph Hospital recognized an opportunity to move beyond a reactive approach and develop a proactive, pharmacy-driven intervention focused on identifying patients at risk before preventable VTE events could occur. They use real-time electronic health record data, standardized pharmacist workflows, and close collaboration between pharmacy, quality, and clinical teams. They significantly improve VTE prophylaxis rates while also reducing pulmonary embolism events that were not present on admission. The success of their work was so impactful that it has been adopted as a permanent practice at St. Joseph Hospital, is now being expanded across other CommonSpirit Health facilities through the South region. Their experience provides a practical example of how hospitals can leverage data, clinical expertise, and interdisciplinary partnerships to improve both CMS measure performance and, most importantly, patient safety. It is my pleasure to introduce our presenters from St. Joseph Hospital. Dr. Monica Owen is a clinical pharmacist specialist at St. Joseph Hospital with board certifications in pharmacotherapy and critical care pharmacy. She's played a key leadership role in developing and implementing a pharmacy-driven VTE prophylaxis program that leverages real-time EHR data and standardized clinical workflows to identify and intervene on prophylaxis gaps. Her work has contributed to significant improvements in VTE performance and patient safety outcomes across the organization. Our other presenter, Dr. April Jennings, serves as the Director of Quality and Patient Safety at St. Joseph Hospital. She is an experienced healthcare quality leader with expertise in performance improvement, regulatory compliance, patient safety, and CMS quality measures. Through her leadership and partnership with clinical teams, she's helped guide the implementation and sustainability of St. Joseph Hospital's proactive VTE prevention strategy, creating a model that is now being shared across CommonSpirit Health facilities. Please join me in welcoming Dr. Monica Owen and Dr. April Jennings from St. Joseph Hospital as they present Preventing the Preventable, Enhancing the VTE Prophylaxis in Hospital Settings Through Pharmacy-Driven Intervention.
Thank you so much for that wonderful introduction, and thank you for the Kentucky Hospital Association for extending the invitation to come and present our work today. We are very excited to share this with the team, as we do hope not only can this impact our patients we care for here at St. Joseph Hospital, but then also for our patients across Kentucky. We did want to go ahead and just include some of the abbreviations that the team will be seeing throughout our presentation, and this will be available for reference after this presentation today. I did want to provide a little bit of background about St. Joseph Hospital as far as our ministry. Of course, we were founded in 1877 by the sisters. We are currently located right in the heart of Lexington, Kentucky. Currently have 433 hospital beds with a 35-bed ER. And of course, we serve both Central and Eastern Kentucky. And we do have our mission and vision here, which I do think that this project is just a testament to how we are really trying to further the care and outcomes of those that we serve, really focusing on that collaboration piece for our values. And I have to say thank you, Jessica, for that wonderful introduction. Why the focus? I think if anyone on this call is familiar with ECQMs or those electronic clinical quality measures, we know sometimes it can be very difficult to kind of get our hands wrapped around those. And this is one of the reasons why CommonSpirit Health really selected this measure, not only for us locally here in Kentucky, but across our national ministry to focus on. Luckily, we do share data amongst all of our facilities across the nation through our risk methodology program, which is MIDAS, which allows us to not only look at population health by state, region, or just central location, but also nationally. So this is something that was actually found nationally as an opportunity as far as reducing the rates of VTEs or venous thromboembolisms across the nation. Many of these facts we are already covered in the opening. And what I really like to focus on is that it truly is preventable. When we look at the rates of mortality and morbidity in these patients, those rates do significantly increase with any hospital-acquired VTE. And when we look at the literature and really the evidence, it does find that one of our largest overarching opportunities is the use of chemical prophylaxis in appropriate patients. As with any quality improvement initiative, of course, one of the first things we have to do is dispel the myths and the rumors regarding commonly held clinical factors. So really, we call this our Mythbusters. A lot of the common feedback or hesitancy we had received when we really started to focus on this initiative regarding improving rates of chemical prophylaxis prescribing was that I'm afraid my patient is going to begin to bleed out. I'm afraid we're going to have complications associated with that. What if my patient falls and hits their head? What are we looking at? So when we look at the literature, we actually found that through some randomized controlled trials that really we're looking at minor issues and complications when we're looking at the use and administration of our chemical prophylaxis. We can see there bruising, hematomas were the most common. And when we think of those really rare or significant or severe side effects from chemical prophylaxis, we start to look at bleeding, things of that nature. You can see the rates of that were really low when we're looking at that randomized controlled trials. So really we can bust this myth in that really utilizing chemical prophylaxis does not increase that risk of severe complications. It's actually safe and effective in appropriate cases. Oftentimes, we see clinical rationale for not prescribing chemical prophylaxis being, well, my patient is alert, oriented, competent, they're ambulatory, they're relatively young. I see no need to administer any type of chemical prophylaxis as they're not for increased risk. Well, we did find some studies that did support that, yes, early immobilization is very important for the reduction of VTEs. However, we found that when coupled with chemical prophylaxis, we actually see a significantly reduced risk for our VTEs. You can see here, looking at our early mobility group, for those that are not receiving any type of chemical prophylaxis, we did see a risk of 10.6 versus that 3.3 when being treated appropriately. So the myth has been busted as well that ambulation alone is enough prophylaxis for our physically capable patients. They really do benefit from that additional prophylaxis. And this is going to lead into Monica and her project. Monica was so gracious to volunteer to be our project champion and lead for St. Joseph Hospital and really going and initiating, singing, and then I will say implementing the ongoing program at St. Joseph Hospital.
Thank you, April. Good afternoon, or good morning, I guess, everyone. So The project that I did started locally within just St. Joseph Hospital, and a quick SBAR breakdown of the project. We are being faced with a situation where St. Joe Hospital was 27th percentile for VTEs not present on admission for fiscal year 25. And with this being a new CommonSpirit goal that we're looking at for fiscal year 26, our target goal was to be 55th percentile. So, digging into the background of this, as we've discussed this morning, developing a VTE during a hospitalization could increase length of stay, which is not good for the patient, nor is it good for facilities. So, brainstorming from a pharmacy perspective, involving pharmacy in this, what can pharmacists do? Well, medications become, the obvious answer that we can do. So we can start optimizing and prioritizing the way that we look at patients on a daily basis to see if they have chemical VTE prophylaxis ordered. If they don't, should they? Is there a good clinical reason why they do not have prophylaxis ordered? And then see if we can increase the rates of chemical VTE prophylaxis ordered, and do we actually see an effect from that? So, digging further into the statistics that we had for our hospital for fiscal year 25, our DVT not present on admission rate was 2.9 per 1,000 acute inpatient encounters. And for PE not present on admission, it was 1.5 per 1,000 acute inpatient encounters. And then moving into the recommendation of this, as I kind of alluded to earlier, just implementing a pharmacy-driven focused review of patients who don't have orders for chemical VTE prophylaxis should help us target decreased incidences of VTEs during hospitalization. So these were kind of the statistics and metrics that I was looking at moving into the project. So we've already talked about the rates in our percentile ranking. So what I'll focus on here is the amount of chemical VTE prophylaxis orders. So the baseline, this is a number that I gathered over 2 weeks of data from a report that I was running on a daily basis to look at how many of our inpatient admissions had an active order for any kind of anticoagulation, not necessarily what we think of as a prophylactic dose, but were they on a treatment dose of enoxaparin or heparin, or were they on a treatment dose of an oral anticoagulant? So those were all kind of grouped in with chemical VTE prophylaxis. And what I found in that 2-week period that I was running this report was that we had 67% of our inpatients admitted that had an active order for some sort of anticoagulant. Now, thinking about realistically, how can we affect this number? How high can we get? Best possible would be 100%. It'd be great if everyone that was admitted could be on some sort of prophylaxis, but we were just reaching for a goal of a 10% increase here. So going to a goal of 77%. So this project overall kind of started late June of 2025. And that included, building up the background, figuring out what needed to be done, getting reports built, and then figuring out the best way for pharmacy to really get into this and assist things. And then this whole process locally ended mid-September. So the standard work and the standard specifications that we used throughout this project, we're running a daily report that April so kindly helped me build in Epic. And here's kind of a screenshot of the things that the report would pull in for Epic for us. So every day, the pharmacist, once this project got rolling after the baseline data was collected, my fellow colleagues in clinical pharmacy would run this report for the units that they were covering. And what this report would pull in would be all the patients that they had, including their admitting provider, how long they've been here, code status, because if patients were listed as comfort care, we were not going to intervene on them. And then it would pull in things like, do they have mechanical VTE prophylaxis ordered? Are the devices being documented on? Because that was also helpful to know what risk level is being calculated for their VTE risk within Epic. Do they have a current anticoagulation med ordered? Because that helped us filter out who we did not need to be focusing on. And then we also pulled in some of these other risk scores. I will say one of the hiccups that we found with this report that made things a little harder was anyone that was on a therapeutic heparin drip. It did not show up in the anticoagulation meds of this column. So that did kind of require a little bit of a deeper dive on our end. So once we would run this report, we would evaluate the patients. If they didn't have an order, we would look into the chart, are they here for some sort of bleed? Are they here for some sort of surgery where it's on hold? And we would dig in to see if there was a good clinical reason why anticoagulation was being held. If we did not see one on our review, we would reach out to the admitting provider and we would recommend addition of either enoxaparin, maybe heparin, or if they were on therapeutic anticoagulation at home, recommending to resume that. Now, part of this was for the ease of collecting data on my end was documenting these findings in a spreadsheet that we all shared. But additionally, we were documenting our interventions within the IVent system of Epic. So we had multiple places that documentation was occurring just for the sake of ease of data collection and then just documenting what we were doing. So here is a graphical representation of the work that we were able to achieve. So on the left in the blue is the baseline. This is where I was running that report on a daily basis to see how the average of chemical prophylaxis orders that we had on patients. And through those 2 weeks, we had an average of 67% of patients being covered with chemical VTE prophylaxis. So in the 3-week time period on the right in the green, this is where pharmacy is doing a focused review of these patients. We are running the report. We are looking into it to see if the patients have a contraindication to not be on chemical prophylaxis and recommending addition of it. And throughout those 3 weeks, we were able to drastically increase the amount of patients being appropriately covered with VTE prophylaxis to 80.84%. So just kind of reflecting overall on the project, because again, this was started as a local project just to see what we could do within our facility. We were able to increase the amount of chemical prophylaxis orders to 13.5%, which exceeded my original goal of 10%. And I thought that was excellent. As far as continuing the standard work, because we found such success with it, we did decide to continue it. However, we no longer document in the spreadsheet. It just wasn't feasible to continue doing duplicate documentation, and the spreadsheet's main purpose was ease of data collection for myself. As far as the interventions go, so we talked about, we were also documenting these interventions in Epic, and during the baseline period where we were not running this report, we had 14 interventions documented for adding anticoagulation, and then in our improved phase where we were actively running this report, we more than doubled our interventions to 31. And then throughout this project in the background, and then even after the project ended, we had continued enhancement of our clinical decision support tools at a national level. So we had improved VTE risk clinical decision support tools and optimized VTE prophylaxis order sets ongoing. So for the current state of what we're doing now, so just trying to sustain the effectiveness of what we're doing, we have more personalized EHR tools that have come after this project through regional and national efforts to optimize the way that we're using our electronic health record to further identify patients and get them appropriately covered with chemical VTE prophylaxis. We have daily assessment and multidisciplinary rounds, so from both a pharmacy, a nursing, a physical therapy, a physician. There are a lot of different teams working together now to ensure VTE prevention. And then we have since also had new VTE order sets rolled out. They are embedded in our admission order sets now. So they are there and they are intuitive, and Epic is working in the background to point the physician in the correct dose to order on admission based on patient demographics. So we, within the pharmacy workflow, so we do still have that report option if a pharmacist wants to use that. We also have more personalized things within the patient list that we can use. So you can use things to look at their history, their current diagnosis. You can also look into, do they have current anticoagulation ordered? And you can do all of this on just your patient list rather than having to run a report daily. So this is left up to the pharmacist that is whatever workflow works best for them. So within multidisciplinary rounds, we have active pharmacist participation in both floor and ICU rounds. And then again, continuously looking at the risk in the ordered VTE prophylaxis. So this is a screenshot of what some of the things look like as far as VTE risk assessment and clinical criteria built in with us to Epic. So Epic will look at the patient's chart and run some stuff in the background to determine if they are high, moderate, or low risk for VTE. And this risk score is largely driven from the UC Davis 3-bucket model, which is why you see 3 different scores there, high, moderate, or low risk. So depending on the user's access within Epic and depending on how they use Epic, because those of you that have Epic know there's a million different ways to look at something, you can determine your best way to see this. So for me personally, I pull this into my patient list every day so I can see which patients have a high or moderate risk of VTE. And the way that Epic, once they calculate this, if they are moderate or high risk, then on this next slide, it will help determine if they need any action as far as VTE prophylaxis goes. So if they are high or moderate risk, Epic will consider that they need VTE prophylaxis and will look to see if it's been ordered. And then it also is looking at their bleed risk. And if they are high risk for bleed and they're on anticoagulation, then it's also saying, hey, maybe we need to evaluate this further. So these green, yellow, and red and the actions needed, these were things that were decided at both a regional and a national level to kind of standardize workflow for everyone on how we can determine who needs to be reviewed and who needs VTE chemical prophylaxis ordered. And then, as I mentioned, we have now updated our VTE prophylaxis standard order. So these are what our standard orders now are on our admission order sets. And Epic will look at the patient and it will look at their total body weight. It will look at their BMI. It will look at their creatinine clearance, assuming that it has been calculated that they have a current weight and that they have a recent serum creatinine. And it will kind of direct the physician on what to order. So if a patient is admitted and they are 40 kilos and the physician wants to start enoxaparin for VTE prophylaxis, if the physician or the advanced practice provider orders it through the general admission order set, they will be directed automatically to order enoxaparin 30 milligrams every 24 hours. So it's very helpful to have Epic be intuitive and help point us towards the most appropriate dosing. And this is dosing that has been done at a national level for the facility or for the system. So current state, where are we looking at? We're almost a year past when this project started, when pharmacy started really diving into these things. And it's changed a lot since the initiation of the project. We went from running a report daily for 3 weeks to then kind of, it's still a priority. We still need to look at, do patients have chemical VTE prophylaxis orders? But, now that we're outside of this project phase of it, you can do that however that best suits you. And so, some of my colleagues look at the report, some of us pull it up on our patient list, and we are now actively rounding both in ICUs and on floors and having these discussions. So our most current statistics for DVT not present on admission is 2.5 with a goal of less than 3. So we are meeting that. And for PE not present on admission, we're at 0.9 with a goal of less than 1.4. So we are also meeting that. So I also wanted to look into, since we are no longer using the spreadsheet, how are we documenting this? Are we capturing that we are adding anticoagulation therapy when we are? So digging into that, for a recent 90-day snapshot from March 11th to June 9th, we documented 86 added drug therapy anticoagulation interventions. But, I also wanted to dig a little deeper into our anticoagulant interventions because it's great that we add it, but that's not the only thing we do as pharmacists. We will make sure the dose is correct. And that means, adjusting it if someone develops an acute kidney injury and now they need a dose decrease or a drug change. We'll also, monitor things. We'll order lab tests. So you can see here another 90-day snapshot of what we're doing. So there are 86 times that we added it, but in the same 90-day snapshot, there were 150 times that we optimized a dose, which I think is just as important as adding it, especially when we're talking about preventing something.
Thank you for that, Monica. And I think what's important too for the success of this project, as with any project, is data transparency. So I did want to share a snippet of the clinical scorecard that's actually built and provided by our national data analytics team. So I did want to provide a trend line for percentile performance over the past fiscal years, as it does show the upward trajectory in our performance when compared to our peers across the nation. This is something that we do review with our executive leadership, and then, of course, the immediate project team on a regular cadence to ensure that everyone is aware of where we're currently performing each month to date. I also do appreciate the availability of the comparison to our South Region partners, as we do have regular check-ins with them regarding our performance and barriers.
Okay, so just some quick takeaways from the project and the things that we've seen go on in the last year. So we know that VTE remains a significant risk. We know hospitalization is one of the biggest risk factors for VTE, especially being in the ICU. So we are continuing to see what we can do to help prevent that. From a pharmacy standpoint, we are doing our part to look at the patients, to continuously assess them, stay on top of appropriate chemical VTE prophylaxis. If there are maybe a patient's on heparin sub-Q every 8 hours and the patient doesn't like having to be stuck every 8 hours, that's fair. If the nurse lets us know that, we can talk with the provider to see if maybe enoxaparin would be a better option for the patient, or maybe a patient needs to be transitioned from prophylaxis to therapeutic for whatever reason, or off of therapeutic to prophylaxis because they're a high bleed risk now. We are here and readily available to help and to continue to review patients for those opportunities. And then, of course, pharmacy, we're doing what we can, but the success of this also comes from interdisciplinary work. So we are working with providers, we're working with nurses. Physical therapy has also been involved a lot now because early mobility has proven to be a big factor too in reducing VTE risk. So, when we're in rounds, both in the ICU and on the floors, the teams are constantly also talking about mobilities and wanting to get the patients up so that we can get them moving. And then another thing within that interdisciplinary success was the order sets. So getting those order sets approved and getting them ordered. I will say, just kind of from my own experience in the last year, once those order sets got embedded into the admission order set with the now approved standard dosing from CommonSpirit, I do feel like I see patients admitted on chemical prophylaxis ordered as soon as they're admitted more often than I was beforehand.
And the project was really the first step, whenever we started doing our deep dives into our cases that we had during our baseline period. But the retrospective reviews and interventions did not stop there. So I know previously we had discussed how many other practices and interventions we had completed here at St. Joseph Hospital became best practices. And the way in which we completed our reviews was also one. So this is actually just a snippet of what used to be known as Google Studio or Looker Studio. I think it now has a new name, that we're actually using to bring in information we're gathering from MIDAS in a standardized format into a usable format to where we can look at trends based on race, age, look at admission or discharge unit, and then also breaking it down by the admitting service. This is something that was implemented here at the Kentucky market level that was actually adopted as a best practice across the South region. And we're actually involved in developing that tool for the other facilities. In looking at the additional information provided from our MIDAS tool, we can actually see that a lot of our opportunities are being broken down by our DRGs. Sepsis, not surprisingly, was one of our top DRGs for VTEs not present on admission. And then when we really started to break down our DVTs, we started looking at them at upper versus lower extremities. So whenever we started looking at that breakdown, you can actually see we're actually having a higher just case volume of upper extremities versus lower. So that really began to kind of shift our focus more so from the chemical prophylaxis to what are the independent patient factors that are leading to these VTE events. Monica did a great job of discussing our MDR process and how they are truly multi or interdisciplinary. And something that we really started to focus on during our MDRs is our ordered activity level. So something that we had seen in almost 30% of our VTE cases is that our patients had an order for bed rest. And we all know in a hospital, an order for bed rest is basically just like an order to basically continue to have debility and weakness. So that's something that we've really started to address, as well as ensuring that we're getting our patients up as soon as possible. Monica, did you have any other input or anything regarding MDRs?
I know from an ICU standpoint, a lot of times they go head to toe. And so they will specifically also address the chemical VTE prophylaxis in that the nurses are addressing that and pharmacies addressing it. If not, again, and also the mobility from a floor standpoint, it's a little bit of a quicker pace than MDRs, but we are still covering all the bases. They are covering the BMAT, the bedside mobility assessment tool level for the patients to determine, if they can get up on their own or if they need assistance and if PT is being ordered. And then, of course, with the pharmacy presence there, we are assessing the patients to see if they have anticoagulation ordered.
Thank you. So when we looked at the next areas of opportunity that we have found based on our retrospective reviews, looking at the sepsis population, something that we're going to begin to develop is looking at the implementation and the intervention specific to the recovery phase. At CommonSpirit, they've actually developed a national sepsis policy, which includes the resuscitation process. What do those guidelines look like? But now we've also defined what does it look like when a patient has entered recovery. So specifically, patients would have to meet these clinical markers or indications, such as the resolution to lactic acidosis, have antibiotics on board for at least 24 hours, and be free of vasopressors for at least 4 hours before they can begin really looking at the steps for improvement and progression of the care. So increased oral intake, the early progressive mobility, and then really engaging in their learning to understand their individual risk factors for developing the sepsis. Specifically for the early progressive mobility, something that we're really focusing on in our intensive care areas is looking at passive range of motion, beginning for those patients maybe who may be ventilated, sedated, and unable to participate, going all the way to ensuring that we're getting our patients up out of bed for meals once they enter that recovery phase. And then also looking at those upper extremity VTE events, looking specifically at our central line utilization. We do utilize a tiered huddle system here at St. Joseph Hospital, actually, and across our market, with our tier ones really kind of being the down and dirty of why do we have indwelling lines, whether that be a catheter or a central line. As far as the clinical necessity, is it in the appropriate place? We're really trying to discourage placement and use of femoral lines because, number one, there are risks for infection, but then also they can deter ambulation or mobilization. And then when you look at the placement of our midlines and our PICs, this is something that we're really starting to work with our PIC teams on, or central line teams, as far as if we have any concerns regarding the vessel health or viability for that central line, are we escalating those concerns to providers? And then specifically for upper extremities, really looking at the catheter to vessel ratios. There are clinical recommendations that we should be keeping those ratios less than 45%. And in patients with comorbidities such as end-stage renal disease, actually possibly less than 30%, to really help reduce that blood velocity going around that line and decreasing that risk for possible VTE events. Literature also suggests VTE events in the upper extremities are actually at higher risk for morbidity and mortality when compared to lower extremity, which I found to be a very interesting statistic. We did discuss the national implementation as far as the work that has been done. Monica did a great job of describing how we really utilize and flex the technology within our electronic health record to build reports that unfortunately did have to be manually ran to really kind of get that list with those opportunities. So beginning at the South region, we started to actually partner at the elbow with our Epic designers and forgive me, I'm going to call them analysts. I'm sure they have some wonderful other title or name to really build a interactive dashboard that's also in Google Studio. So it's accessible to anyone with a CommonSpirit license that will automatically refresh every 15 minutes with information pertinent to VTE prevention. Specifically going outside of that realm of chemical or prescribed prophylaxis, we're beginning to pull in a lot of that nursing care that can influence or impact the reduction of VTEs, whether that is the mobilization, the order and application of the pneumatic compression devices or mechanical prophylaxis. And then when we're looking at the administration of the medications, is that medication truly being given? One of the myths that I didn't take time to dispel, but I think sometimes we see frequently in the clinical setting, is that nurses will sometimes hold chemical prophylaxis if there is a thought that someone may be going to surgery or have a procedure and they don't want that patient to potentially have a bleed or be at risk for a hematoma. However, literature suggests that's actually counterintuitive. So this dashboard will allow our leaders, whether it be nursing, physician, or pharmacy, to really kind of see not only what's prescribed, but what are the actions associated with those interventions. And having that really available will really help to decrease and improve the workflow for those individuals. That way it's really available and doesn't take, I will say, an unnecessary amount of button clicks. So we're currently in the testing phase for the South region, and hopefully we'll be going live with this by the beginning of the fiscal year. So we're very excited for this. And that brings us to the end of our presentation. I would look forward to any questions that the group may have for us.
Oh, that was a wonderful presentation, and thank you all so much for sharing your expertise. We do have some questions in the chat. Do you have a list of exclusions?
So I will go ahead and just kind of chime in a little bit. So we actually, in the EPIC reporting, did pull in the exclusion list specifically for VTE 1 and 2. That way we could go ahead and exclude those populations. And I know Monica already mentioned the comfort care population. Monica, is there any other group that I may have missed?
No, I will say when we were looking at this, the report did have the exclusion based on those two measures, but we also dug into it a little further to see if the patients had exclusions outside of things that were being gathered by that measure, because there are some clinical conditions that come up throughout a hospital admission that may preclude a patient from having VTE prophylaxis. So the numbers that I reported and that you saw did reflect maybe some additional patients that were excluded that were not necessarily excluded by the measure itself.
Did it decrease your PSI 12s?
I'm actually pulling up my dashboard now. So speaking purely per case volumes, yes, it did. And I think, again, anyone who's dabbled in the patient safety indicators know the barriers we sometimes have with that PSI 12 measure just based on the patients coming in. Sometimes they're transferred to us. They already have a known condition that may predispose them for a VTE. But yes, we did actually see that decrease, and I will type in that volume and rate for you guys in the chat box in just a moment after I verify it.
Okay. Well, while you're typing that in, maybe Monica can answer. Did the doctors have a workaround for the VTE order sets?
So the VTE order set that we showed with the standard doses is built into the general admission order set. The physicians do not have to order anticoagulation from that. There is an option for them to not initiate anticoagulation, but they do have to give a reason. So they can say that the patient is low risk for VTE, so they're not going to order it. They can say the patient is a high bleed risk, and that's why they're not ordering it. And that is something that it takes a little bit of searching around an Epic to find, but if you know what you're looking for, you can go find the order from where they said no VTE prophylaxis or no chemical VTE prophylaxis indicated. And you can see the answer that they gave to that question. So that does help us, today when we're reviewing patients. Additionally, within that order set, and I'm not super familiar with it because I'm not the one ordering mechanical VTE prophylaxis, but there is an option in there that they can say that they're going to do mechanical versus chemical, or, no mechanical prophylaxis indicated. So the order set doesn't necessarily force them to order chemical prophylaxis if they don't think that it is indicated, but they do have to give a reason why they are not if they choose not to.
Do you have any problems with them saying the word other? And then how do you overcome that if there's really not an explanation?
I have not noticed that lately. I think sometimes the default may just be to say low risk for VTE, even if by all definitions they may not necessarily be low risk for VTE. I don't know that I have seen any issues with them just kind of picking other as a catch-all, but that does happen on other things.
Yes. I feel like you might have answered this, but I'm going to go on and say the question. Is your VTE risk assessment based off the VTE1 and VTE2 measure for patient inclusion?
So the risk assessment of itself is built off of that EPIC methodology, which kind of runs in the background, which updates frequently. For the purpose of the report that we did develop, we did pull in that inclusion and exclusion criteria, just so we could be mindful at the interventions that Monica and team were completing. I will say, just kind of going back to the order set discussion, we have a lot of providers who are technology savvy and they will create their own order sets. And, sometimes they would not include those. We did partner with our med staff team and then also our physician clinical informaticist to really do some focused education during like our internal medicine meetings, our emergency medicine meetings, to really discuss why we need to be incorporating that risk assessment upon admission. And I am going to reshare my screen real quick regarding the PSIs, because I know a lot of work, a lot of focus about PSIs. So you can see actually here in 2024, we did have rates as high as 4.57 per the 1,000 admissions. And here in 2026, we're seeing a cumulative 2.53.
Thank you. Is there anybody that has any other questions that would like to come off mute? I'd say congratulations, great work. I know that while we're waiting on any other questions, how did you get provider buy-in?
I'm going to say probably from my perspective, it was a little easier because, I'm not necessarily there on the front line with those caregivers, but definitely with the leadership team, looking at the evidence and really kind of getting the why behind our action. I will say that once we started standardizing the work, once everything we started to see here locally was catching regional and national attention, and we started to standardize it, I think at that point in time, I think everyone was on the ship. Monica?
Yeah, I think I agree. I mean, and then from a pharmacy standpoint, provider buy-in, not necessarily from like order sets and things like that, but just being willing to have the clinical discussions in real time, in rounds, and discussing evidence-based medicine, I think helps us. And it also, improves the relationship that we have with the physicians, where if we can actually come with evidence, either like patient-specific evidence or clinical, evidence-based medicine from other sources, they're willing to have those discussions with us.
So for some of the smaller hospitals that have only one pharmacist with the whole hospital, what is your recommendation on how to get this type of program and apply it to their type?
Yeah, so we actually had those discussions because, this project started locally and then it kind of went within the Kentucky market where, St. Joe Hospital is the biggest St. Joe hospital within the state. And so we do have smaller facilities in Mount Sterling and Berea who do only have one pharmacist doing this. And I would meet with them and we talked about running the report. And again, during the project, the report was what we deemed the best option for this. But with this garnering the attention from a regional level and then a national level, and as these EHR tools were being built, and you could now, if anyone that uses Epic and you're familiar with the patient list, you can customize it and build it to those things. So I met with some of these pharmacists virtually, and we talked about what you should be pulling in that can help optimize and can point you to that. So some of the things that I use and that I had recommended that they use to pull into their patient list were a column that pulls in if they have anticoagulants ordered. And the biggest difference between what we were seeing in the patient list and what was coming in the report was that the patient list was pulling in that heparin drip that wasn't being pulled in from the report. So now we're automatically, having better success with seeing the amount of correct anticoagulation orders, and then also pulling in the VTE risk score and the assessment of whether or not Epic in its reporting was determining if the patient needed review by pharmacy. And that just kind of gives that single pharmacist who's responsible for a lot of patients a quick glance to be able to scroll through Epic and see, oh, it got a 2. That means pharmacy should probably review it and see if they need anything. And you can also leave yourself notes or mark something as reviewed sometimes in Epic. That kind of helps you not duplicate that review, the next day when, again, it's just you and you have a lot of patients to look into.
So potentially, if you didn't have Epic, you could probably use an Excel form, I would say, to gather that.
And, depending on the other EHRs out there, I'm sure there are ways to better optimize that. I think if you are just one person trying to do this, it's really leveraging your EHR to your own workflow and how you can best identify someone that you have not reviewed, and do they need, at a quick glance, do I need to be investigating their anticoagulation status or not?
We had another question. Was there specific resources you use to support physician buy-in?
Yes, there actually was. And I'm going to piggyback to the other question in just a second. Again, we were not alone in this. This was a national initiative. A lot of the resources and tools we use. We don't want to recreate the wheel, right? We have other efforts and initiatives our time could be dedicated to. So something that I really enjoyed using with the caregivers were our Mythbusters. We did a great synopsis of those for this group, but it was really almost like in a game show type of format, which I thought was super beneficial, because as you're going through it and they're trying to apply it to the scenario, sometimes they get the wrong answers, which I thought was great. And kind of going back to the previous question, if you're a facility maybe who does not have Epic or an EHR that you're able to leverage this type of data, one of the Mythbusters is really, who all needs anticoagulation chemical, prophylaxis when admitted to the hospital. Really, the answer is everybody, regardless if you're 30 years old and a normal BMI, or if you're someone who's 69 and in there with a hip fracture. Then we're just looking at the dose appropriateness, because any prolonged immobility will increase that risk. And I think that was probably one of the more, eye-opening things, So really, sometimes it's just starting with, does everyone have it? And if you don't, what's the reason?
Impressive work, great job, was another comment. Is there any other questions for St. Joe? Well, with none being, I'll let everybody have about 8 minutes back to their day. I really appreciate you all coming and discussing your project. It's a fantastic project that I think could be scalable to any size hospital. So thank you very much, and I appreciate your expertise, and thank you everyone for joining today's KHA Quality Webinar. Have a great day.